let's see. You have several conditions that can cause acute abdominal pain. Hospitalization is usually required. Don't spend time on scene trying to figure out what exactly is going on. You just need to know they're having abdominal pain and you need to get them to the hospital. Abdominal contents that are acidic or alkaline that leak into the abdominal cavity and irritate the peritoneum can produce a sudden onset of severe, sharp, and constant abdominal pain. And these are some of the things that it can be. Peritonitis, appendicitis, cholecystitis. What is that? Cholecystitis is your colon. Are y'all sure about that? No, it's not. It's your gallbladder. Hepatic ulcer disease, hernia, aneurysm, abdominal. Peritonitis occurs when blood, pus, bacteria, or chemical substances leak into the peritoneal cavity. The onset and type of abdominal pain that a patient experiences are somewhat dependent on the type of substance leaking into the peritoneum. As an alternative to the rebound tenderness test, the Markle test has been shown to be just as reliable, but without the number of false positives or negatives seen with the rebound test. For the Markle technique, instruct the patient to stand on their feet with their knees straight. Ask them to raise themselves up on their toes and drop suddenly down to their heels, flat-footed, with enough force to produce an audible thump. Appendicitis is an inflammation of the appendix that commonly causes an acute abdomen. Appendicitis is usually caused by a blockage in the intestines and results in inflammation and irritation. If left untreated, the inflammation eventually causes the tissue to die and rupture, and you can die from this. You will become septic. Some of the signs of appendicitis. Periumbilical abdominal pain, localized to the right lower quadrant. Nausea, vomiting, low-grade fever, chills, lack of appetite, abdominal guarding, and a positive Markle sign.
So the Markle test is just like doing the rolling on it?
You roll up on your toes and then just fall back down on your heels.
Oh, that's not.
Huh?
I thought it was like the rolling on the abdomen.
No. Alright, pancreatitis is inflammation of the pancreas and cause severe pain in the middle of the upper quadrants, epigastric area of the abdomen. This abdominal pain sometimes radiates to the mid to lower back. Alright, you can have jaundice, fever, signs of shock. Most of the time you'll see this in alcoholics. Inflammation of the gallbladder is commonly associated with the presence of gallstones. This condition rarely occurs in children, but it can. I've seen them as young as 14 have their gallbladders removed. In some cases of cholecystitis, the gallstones actually block the opening of the gallbladder to the small intestines. This blockage causes an increase in pressure inside the gallbladder, which can create severe pain. This, like your appendix, can also rupture and you can die from it. Definitive care is hospitalization and sometimes surgical intervention to remove the gallbladder, stones, or blockage. If left untreated, tissue death, perforation, and pancreatitis can occur. GI bleeding most commonly affects people in their 40s to 70s, but children and younger adults can have GI bleeding too. Alright. What is hematemesis? Vomiting blood. Hematochezia. Melena. Okay. So, some of the signs and symptoms of GI bleeding: abdominal pain, tenderness, the hematochezia, melena that we discussed, and altered mental status, weakness, syncope, tachycardia, and shock. Esophageal varices are caused by increased pressure in the venous blood supply system of the liver, stomach, esophagus. This is known as portal hypertension. When these rupture, they bleed a lot. very hard to control. You can't get pressure to your esophagus very easily. But however, it is usually painless. Alright? Jaundice is yellowing of the skin or the sclera of the eyes from liver disease. Okay? With esophageal varices, they will have large amounts of bright red blood, no pain, rapid pulse, difficulty breathing, pale, cool, clammy skin. Varices are usually identified with painless bleeding in the digestive tract. Bleeding can be profuse and lead to shock. That's what one looks like under an endoscope. They will pop, rupture.
So on these patients, what would a chief complaint be if they're not having it done?
Profuse bleeding. Gastroenteritis is inflammation of the stomach and small intestines. It is commonly associated with the presence of abdominal pelvic pain. This condition can be chronic or acute. You will see this a lot also in alcoholics. Okay. If left untreated, it can result in the breakdown of the mucosal layer in the GI tract. This breakdown can lead to dehydration, hemorrhage, ulceration, and perforation. If you perf your bowels, you can become septic and die. Okay? Everything in your bowels, all the good bacteria, all the bad bacteria, everything is going to be in that abdominal cavity. Ulcers are associated with a breakdown of the lining that normally protects the intestines from the digestive fluid contained inside the digestive tract. This breakdown can cause damage to the stomach or intestines, and in some instances, massive bleeding or perforation. This is also a life-threatening emergency. Alright, this is what it looks like under endoscopy. These can also bleed as well, large amounts. Most patients are usually aware of their ulcers and provide you with this information during the history taking process. In some cases, the patient takes over-the-counter antacids or prescribed medicines for this condition. They have a sudden onset of left upper quadrant or epigastric pain, nausea, vomiting, signs of shock, and peritonitis if they perforate. An intestinal obstruction is a blockage that interrupts the normal flow of the intestinal contents within the intestines. This condition can occur in both the large and small intestines and can either be partial or complete. Usually with complete, they have to have surgery. Usually with partial, they usually don't give them anything by mouth. They hydrate with IV fluids and stuff, and they will see if they can get that blockage to move. If they can't, then they go in and do surgery. Alright, the patient with an intestinal obstruction might want to continue to walk and move, whereas the patient with peritonitis might want to lay still and not be moved or touched. Okay? You'll have abdominal pain, nausea, vomiting, constipation, abdominal distension, tenderness, prominent high-pitched bowel sounds, diminished or absent bowel sounds. Most hernias are not life-threatening and can be easily treated. However, hernias can become life-threatening, okay? What is a hernia? It's protrusion of the intestines through the opening or weakness in the abdominal wall. If they become incarcerated, okay, it means the intestine has turned over on itself and it's being squeezed where it's like suffocating, okay? All the blood flow to that part of the intestine is becoming, it's not getting it anymore. Alright, what happens when we don't get any blood flow? It dies, alright? If it gets too bad, they'll have to go in and resect part of the intestines or the bowel. In some cases, hernias can become incarcerated or strangulated. Alright, produces an obstruction. They'll have abdominal pain with lifting or straining. A lot of times you can feel these hernias. Rapid pulse, tender mass at the site of the hernia. Aneurysm can eventually rupture and is one of the most lethal causes of abdominal pain. Alright, most of the time there's nothing you can do about this. Whether you're a basic, a medic, a flight medic, it doesn't matter. It better rupture, and you better hope you have a really good cardiothoracic surgeon, and you are literally intubated and on the table when it ruptures. Most common in men over 60. AAA is weakened, ballooning, an enlarged area of the wall of the abdominal aorta. This is what it looks like. Alright, another condition involving the aorta is an aortic dissection or a dissecting aorta, which begins with a small tear at the intervessel structure. It enables blood to leak between the walls of the aorta. Alright? There's so much pressure in there that blood keeps dissecting it till it gets to the end, and then it rips and tears all the way through. You start bleeding out in the abdominal cavity. The process of dissection continues with increased pressure until the outer wall is damaged and blood leaks out behind the peritoneum or into the abdominal cavity. These will have gradual onset of lumbar growing and abdominal pain with rupture. They will have a sudden onset of severe constant pain in the lower back, flank, or pelvis, and they will describe it as tearing. Can also cause testicular pain. If you suspect a patient has an abdominal aortic aneurysm, do not palpate the abdomen. If you palpate the abdomen, what are you going to do? You're going to rupture it, okay? Pressure or excessive movement can aggravate the aneurysm, causing it to leak and rupture. A pulsatile mass may be felt. The abdomen may be rigid and tender if rupture has occurred. Assessment for shock is crucial. Transport without delay. If the rupture is in the process of occurring, this is an absolute emergency. You should be concerned when diarrhea has persisted for days, hours in the case of vomiting, and the patient has become dehydrated, okay? I don't understand why people, it's like, if I feel sick or if I have diarrhea or whatever, I don't take something for that. Like, that's my body trying to get rid of something that it doesn't need. Like, okay? Your body has a reason behind what it's doing. It may be bad food or whatever. Anywho, it's just my little.
She won't go to the doctor for anything.
Young pediatric patients, especially infants, cannot effectively describe their symptoms. Therefore, you need to collect as much of the history as you can from the parent or primary caregiver. It is important for you to transport any child suspected of having abdominal pain, even if the vital signs appear to be within the normal limits for the child. When conducting a history on immunocompromised patients, it is important to ask about fever, vomiting, diarrhea, similar episodes in the past, and any recent changes in medication or treatment. Be sure to ask any transplant patients about the date and location of their surgery. They probably, more than likely, need to go back to wherever they had their surgery done, right? All right, bariatric surgery patients. Within 1 year of surgery, 20% of post-bariatric surgery patients are admitted to the hospital. Within 3 years, 40% are hospitalized. Abdominal complaints in post-bariatric surgery patients could be an indication of a serious condition. All right, abdominal pain lasting longer than 6 hours, regardless of intensity, is considered a medical emergency. Assess the patient with an abdominal emergency for signs of shock. Palpate the least painful area of the abdomen first. Why would we do that first? Are you gonna be able to see actually how bad it hurts if you start with that and everything else gonna hurt? Movement of the diaphragm may increase abdominal pain, causing shallow breathing. Allow the patient to assume a position of comfort for transport. Alright, scene size up. Take your standard BSI precautions. Look for any kind of mechanism of injury. Look for any indications of bleeding, vomiting, or medications used to relieve abdominal pain. A person with an acute abdomen generally appears ill and assumes a guarded position with their knees drawn up and their hands clenched over their abdomen. Alright? You'll be able to tell if somebody is sick or not sick. Okay? I don't care if you've ever laid eyes on them before. You can tell if somebody's hurting or they're not hurting. Make sure your airway is open. Be alert for vomiting and assist ventilations if you need to. Shock is the only one indicator that this is a serious medical condition. The patient with an acute abdomen should be categorized as a priority for transport if they meet any of the following criteria. They have a poor general appearance. They're unresponsive, responsive but not following commands. Signs of shock, hypotension, narrow pulse pressure, tachycardia, pale, cool skin, and severe pain. You want to look for signs of shock. A rapid 30 pulse, restlessness, cool, clammy skin, and as a late sign, hypotension. If the patient is responsive, first conduct the history. If the patient is unresponsive or has an altered mental status and cannot respond appropriately, conduct the history after the physical exam and vitals. And gather information from family or bystanders. You can go over your OPQRST questions. Y'all know what OPQRST stands for? Yeah. Conductor's sample history. What?
I think RST.
Radiation, severity, time. Do they have a history of abdominal problems? When's the last time they ate or drank? If more than one EMT is on scene, the physical exam can be conducted and baseline vital signs can be attained by one EMT while the other is gathering the history. Alright, has their appetite changed? What color was the patient's last stool? They had any difficulty urinating? What were they doing when the abdominal pain started? You want to note any involuntary guarding, which is an abdominal wall muscle contraction that the patient cannot control, resulting from inflammation of the peritoneum. You want to begin palpation with the least painful area. Okay. Assess if the abdomen is tender or non-tender while touching. Right? When palpating the abdomen, note any masses that are present. Are they pulsating? Ask the patient if they have pain in other areas. Document the quadrant in which the pain is located. Clinically, it is important to recognize the contraction of abdominal muscles and proceed as if an acute abdomen is suspected. Respiratory rate may increase and breathing may become shallow. Pay attention to blood pressure and heart rate. Decreased blood pressure, increased heart rate, and pale, cool, moist skin are indicators of shock. Severe abdominal pain activates the sympathetic nervous system. This causes an increase in heart rate, respiratory rate, blood pressure. Can cause the skin to become pale, cool, and clammy. These responses can be mistakenly interpreted as indications of hypovolemia. Can also have fever, chills. In infants and children, suspect an acute abdominal emergency if tenderness or guarding upon palpation is present. Do not waste time with extensive exams or palpation prior to initiating transport. If the SpO2 is 94% or greater, no other signs of respiratory distress, hypoxia, hypoxemia, or poor perfusion, there's no need to administer supplemental oxygen. Only if they're less than 94. Have signs and symptoms of hypoxia, respiratory distress, poor perfusion. Give them nothing by mouth, okay? This little algorithm should be in your book. If signs of severe hypoxia are present, a normal breathing mask of 15 liters could be used to quickly achieve SpO2 of 94%, then change to a nasal cannula to maintain 94%, especially if the patient can't tolerate the normal breather. You want to keep these patients as comfortable as possible, treat for shock, and initiate transport.